Dear colleagues, welcome to my presentation about theoretical approach to cardioneuroablation strategy. As you know that ablation of ganglionated plexus or cardioneuroablation is an emerging strategy for cases with vagal-mediated bradyarrhythmia. However, to perform ganglionated plexus ablation, we should understand autonomic innervation principles of the heart. And in this first lesson, I will try to explain anatomophysiological background of cardioneuroablation based on GPs. Cardiac innervation consists of parasympathetic and sympathetic systems. As in all other organs, autonomic nerve system can be divided into extrinsic and intrinsic parts according to course of nerve fibers and synaptic junctions. Preganglionic synaptic fibers are largely derivated from medulla spinalis, and then postganglionic synaptic fibers are located in these major autonomic ganglia along the cervical and thoracic spinal cord, which is called as stellate or cervicothoracic ganglia. In parasympathetic system, preganglionic fibers originate from medulla oblongata and are carried almost entirely within the vagus nerve. As opposite to the sympathetic system, the axons of presynaptic parasympathetic neurons extend from central nervous system to GPs, which are either very close to or embedded in the heart. So the postsynaptic parasympathetic nerve fibers are very short in parasympathetic system, whereas the neuronal body of the postganglionic sympathetic and sensory neurons is located far from the heart. Most of vagal nerve fibers converge at a distinct GP between superior vena cava and aorta, which is called as aorta superior vena cava GP, and then travels into the sinus and atrioventricular nodes. As you see in this figure, intrinsic cardiac autonomic nerve system forms a complex network composed of ganglionated plexus concentrated within epicardial fat pads in distinct and well-defined area of atrial wall. In C, if you look at the microscopic appearance of the 1GP site, we can see clustering of different neuronal cells within the GP sites. These slides demonstrate the construction of a 1GP site. As you see, GP neuronal network comprises a heterogeneous population of neurons made up of autonomic, parasympathetic or sympathetic efferent neurons, local circuit neurons, and afferent sensory neurons. In the current technology, specific identification of neuron types inside or within a GP site can be demonstrated by using immunohistochemical staining techniques. According to this, we can see sympathetic staining in nerve fibers around intrinsic cardiac neurons, but this staining is faint or absent in neuronal cell bodies. Contrary, parasympathetic staining is notable in neuronal cell bodies and generally less intense in surrounding nerve process. However, we should remember that co-localization of both parasympathetic and sympathetic staining may also be seen in some cell bodies. So, theoretically, we should understand that in a GP site, we usually see neuronal body of parasympathetic system, whereas axonal fibers of sympathetic systems. This slide from Professor Pachon's study and clearly demonstrates selective parasympathetic denervation hypothesis. So, if you remember the immunohistochemical staining in the previous slide, if you can truly detect the localization of GPs and if you apply radiofrequency ablation in any GP site, your lesion will affect sorry, I will try to use pointer. If you perform ablation in a GP site, your ablation will affect neuronal body of parasympathetic system, whereas in sympathetic and sensory system, your lesion will affect axonal fibers of these systems. So we know that neuronal bodies cannot be regenerated after any damage. So your lesion will be permanent in parasympathetic system, whereas in the other system, your lesion will be transient due to axonal regeneration process in the long term. But we recently realized that cardioneuroablation may also cause some sympathetic denervation, because we demonstrated a significant decrease in QTC level after cardioneuroablation procedure, and the main pathophysiological explanation of this response was sympathetic denervation. And if you look at here, as you see that this figure demonstrates parasympathetic neurons in right atrium and left atrium levels in endocardial or epicardial sites. But we also see some sympathetic staining in both right atrial and left atrial area, especially in epicardial sites. So this is very important for the future of cardioneuroablation strategy. So, if we can detect the localization of ganglionated plexus, we may permanently ablate parasympathetic or sympathetic innervation. So, we should know localization of ganglionated plexus around atria. There are three mainly used localization nomenclature for ganglionated plexus. In the first one, Armour et al. Defined 9 different GP sites in human autopsy specimen, and then Poe et al. Used high frequency stimulation to demonstrate GP sites, and they defined 5 main GP sites in left atrium. Although they use different namings for GP sites, actually they defined the similar areas in their studies. For example, superior right atrial GP and anterior right atrial GP actually demonstrate the same area. Or posterior right atrial GP and inferior right atrial GP demonstrate the same area. Superior left atrial or superior left GP demonstrate the same area. Posterior atrial left atrial GP and left inferior GP demonstrate the same area. And lastly, obtuse marginal GP and Marshall tract GP demonstrates the same area. However, there was a significant difference between these two nomenclature systems. This was posterior medial left atrial GP. Actually, according to Armour et al., they demonstrated that nearly 33% of all neuronal bodies are located in posterior medial left atrial GP site. But Poe et al. Didn't say such an GP. So this is very important difference between two nomenclature. In the third one, Chiu et al. Defined 3 main stations in a peak experimental study. The first one is aorta superior vena cava GP located between aorta and superior vena cava. The other one is right pulmonary vein and right atrial GP located between right pulmonary veins and right atrium. And the last one is inferior vena cava left atrial GP located between inferior vena cava and left atrium around coronary sinus. This study is very important to demonstrate selective or physiological innervation principles of heart. In that study, you can see before any stimulation, you can see normal sinus rhythm and atrioventricular conduction. But during vagal stimulation with high frequency stimulation, you can see significant bradycardia and then systole during HFS application, high frequency stimulation application. And then authors applied atrial pacing, and there is still asystole due to AV block. So then operators extracted inferior vena cava left atrial GP. If you remember from the previous slide, it was here. They extracted the inferior vena cava left atrial GP, and then they performed vagal stimulation again. You see significant asystole, but during atrial pacing there was no AV block anymore. And then they extracted right pulmonary vein and right atrial GP, and then they performed vagal stimulation. There was no bradycardia. During atrial pacing there was still normal AV conduction. So this slide clearly the right inferior vena cava left atrial GP mainly provide vagal innervation of atrioventricular node, and right pulmonary vein and right atrial GP provides vagal innervation of sinus node. And aorta vena cava, aorta superior vena cava GP is like an head station for parasympathetic innervation of whole heart, and then parasympathetic fibers travel the other sides in other atrial. In current approach, we use 6GP based nomenclature to explain localization of ganglionated plexus. The first one is aorta superior vena cava GP. This is a head station. The other one is right superior GP, located between right superior pulmonary vein and superior vena cava. The other one is right inferior GP, located in interatrial septum area. The other one is left superior GP, located between left superior pulmonary vein and left atrial appendage in roof area. The other one is left inferior GP or Marshall tract GP, located in lateral wall of left atrium in mitral isthmus area. And the last one is posterior medial left GP or inferior vena cava left atrial GP, located between inferior vena cava and left atrium around coronary sinus. So anatomically, we can understand the localization of ganglionated plexus, but despite our anatomical considerations, localization of GP demonstrates significant difference from one patient to another. So, during electrophysiological study, we need a reasonable method which helps us to determine the estimated localization of GPs. So far, different groups use different approach to detect GP during electrophysiological study: high frequency stimulation, spectral analysis, or empiric anatomical observation. In the first one, by using high frequency stimulation with different hertz or different voltage values, you can see two different responses in different atrial myocardium sites. If you apply HFS in a ganglionated plexus site, your HFS application will cause a vagal discharge, so you will see a prolongation on PP or PR interval like this. They applied high frequency stimulation, and then they see significant asystole in a GP site. However, in normal atrial myocardium site, your HFS application will not cause any significant effect. There are some significant disadvantages of this technique. For example, in the study of Kim et al., just HFS mapping time was more than 1 hour. This is very time-consuming method, because you have to apply HFS in all different atrial myocardium sites, and then they should tag the positive vagal response sites, and then after ablation you have to demonstrate complete elimination of positive vagal response in the same area. Another limitation, there is still no consensus for PROPARE protocol, and again, criteria for positive response are not identical between studies. For some groups use any prolongation on PR or RR interval, but other groups use just second or third degree AV block or asystole longer than 3 seconds. Another and important limitation is it's a very painful strategy, so you have to use general anesthesia if you want to perform HFS application. But for example, in our current approach, we didn't use general anesthesia in any cases because it's very simple ablation technique. And another, and maybe the most usual problem with HFS, inadvertent atrial fibrillation induction. For example, in this case, we can detect the GP site by using electrogram characteristic. You can see here there is a fragmented electrograms, but if we perform HFS in this site, you can see the occurrence of atrial fibrillation. If you see such a response, you have to apply cardioversion, or you have to wait a period to conversion of sinus rhythm. The second one is created by Professor Pachon, spectral analysis by using fast Fourier transform analysis, normal atrial electrograms which demonstrate time to amplitude curve are converted to frequency to amplitude curve, or spectral potentials. With this method, we can differentiate normal atrial myocardium sites and ganglionated plexus sites. In normal atrial myocardium sites, there is very well connected cells with high amount of connection. So conduction is very fast and homogeneous in these cases. So in frequency to amplitude curve, you can see extreme potential like graphic. Whereas in GP sites, there is incursion of the nervous fibers into the myocardium. So in spectral analysis, you will see heterogeneous and fragmented spectrum. But in this you need an offline computer-based converter to apply fast Fourier transform analysis, and all EGMs should be converted to the frequency to amplitude potentials, and there is still no integration with classical 3D mapping systems. In the last method, some groups performed ablation in empirically identified sites. They presumed that yes, we know the localization of GPs and we can empirically ablate these sites. However, in this technique, you should remember that you will apply ablation in just presumed GP sites, and you will have no ablation endpoint in this technique, and you may perform larger ablation because you don't know a real target in this technique. And as another limitation, we recently performed a meta-analysis, and we compared the different GP detection techniques, and we demonstrated that anatomical only approaches are associated with early and high recurrence rates when they are compared with high frequency stimulation and electrogram. So to deal with all these limitations, we try to define a new technique, easily understandable, easily applicable, suitable with 3D mapping system, and which does not require any additional equipment. So if you look at the birth of our electrogram guided strategy, this study is very important to understand our EGM based strategy. By using a classical electrophysiological bandpass filter, Leluce et al. Applied radiofrequency application in different electrogram sites during sinus rhythm in patients with paroxysmal atrial fibrillation, and they demonstrated three different electrogram types. Normal atrial electrograms demonstrate lower than 4 deflections. Low amplitude fragmented electrograms demonstrate more than 4 deflections and lower than 0.7 millivolts. And lastly, high amplitude fragmented electrograms demonstrate more than 4 deflection and 0.7 millivolt. And they compared vagal response during RF application according to these electrograms properties, and the best single predictor of vagal response during RF application was the number of electrogram deflections. So if you perform RF in fragmented electrogram sites, you will see more vagal responses because these sites may demonstrate ganglionated plexus sites. The second most useful predictor was amplitude of. And then Pachon et al. Compared different filter settings to demonstrate GP sites, and usage of 300 and 500 Hz filter setting is better to map GP than classical electrophysiological filter settings. So in our current approach, we change our filter settings from 30 and 500 Hz to 200 and 500 Hz. And by using this technique, we targeted all fragmented electrograms like this, regardless of high or low amplitude, in a region that is consistent with probable localization of GPs. This is important because you can also see fragmentation in anterior wall of left atrium or posterior wall of left atrium, for example, due to fibrosis. So you should check fragmented electrograms in a localization which is consistent with probable localization of ganglionated plexus. This is very important, and you should use 200 and 500 Hz filter settings. Once we detect the localization of GPs, we started ablation from left part, from left inferior GP site or left superior GP sites. And you can see our ablation order from here. First ablate left inferior GP, then left superior GP, then right superior GP, right inferior GP. If there is any AV block history, we can perform ablation in inferior vena cava left atrial GP sites. And after we finished left atrial ablation, we check the heart rate response, and if we cannot achieve the desired heart rate, we can apply ablation in aorta superior vena cava GP site via superior vena cava. Recently, we assessed the vagal response characteristics during RF ablation with different GP order, and we performed ablation in some group. In one group, we started ablation from left superior, left inferior GP sites, and in the other group, we started ablation from right superior GP sites. And in the left side first group, left superior GP was the most common GP site at which a vagal response was observed in 90% of the cases. But in the right side first group, vagal response was seen in only 22% of the cases. So the most important finding of this study is that ablation of right superior GP may hide ablation-related vagal response on left superior GP and left inferior GP sites. So Awareness of this difference, for example, in this patient, we started ablation from left superior GP side, and during RF application on left superior GP, you can see significant asystole during RF application. But in another case, we started ablation from right superior GP side, and then we finished right superior GP ablation. You can see a significant increase on heart rate, but during RF application on left superior GP, there is no more vagal responses. So awareness of this difference may be important if cardioneuroablation will be performed by HFS guided strategy, because right side first ablation may attenuate HFS response on left superior GP and left inferior GP, because you have to use this response as an ablation endpoint if you use HFS application. As a take-home messages, GPs demonstrate clustering in well-defined anatomical areas. Their localization can be detected by spectral analysis or high-frequency stimulation. Usage of fragmented electrograms seems as a new gold standard to detect GPs. An EGM-based strategy can be applied by using conventional electrophysiology and 3D mapping equipment. Thanks for your attention.